Yeah, good afternoon everyone. I'm here to present our study of Association of Antenatal Vitamin A Deficiency, which I'll be calling as VAD, with microophthalmos, anophthalmos and coloboma, which I'll be calling MAC. So it's a part of, the study was conducted along with other institutions of Bodhya Eye Consortium, where institutions have come together to do research. So here in this Bodhya Eye Consortium, we had done another study where we saw the clinical spectrum of MAC, and where we came across the fact that regional phenotypic variation, as in some institutions had more number of cases and more severe cases than the other. So we thought it must be nutritional or environmental factors affecting. So environmental risk factors were studied by only one other study, that is Hornby et al. And risk factors were never explored in both MAC and non-MAC children. So our aim was to explore the association of maternal vitamin A deficiency with MAC and non-MAC patients, to also analyze the association of phenotypic severity, like severe phenotypes, are they having more maternal vitamin A deficiency. So it was a case control observational study where 3 institutions came together and pooled the data. Sampling process was done based on the prevalence of the previous study, and we calculated 220 was the size of the sample. Inclusion criteria for the cases was about 0 to 3 years and consecutive MAC cases. And for the controls, it was 0 to 3 years, but cases of trauma, refractive error, allergic conjunctivitis, and CNLDO, congenital nasolacrimal duct obstruction. It was done between June 2018 to June 2021. Exclusion criteria was when there was unclear diagnosis, mother was unavailable to give the interview, or no perinatal details were available. So we reviewed the case records and we found out that demographic details were noted, antenatal and perinatal history, especially emphasizing on presence of night blindness, birth order, which order of birth was the patient, details of the phenotype was noted, systemic associations, if there were any, were asked to the mother. Whatever remaining data was not there at times about the birth order, small things, that was done by telephonic conversation with the mother. Validated WHO recommended questionnaire was used to ask about the antenatal night blindness, which is an indicator of maternal VAD in mothers. Some phenotypic definitions are anophthalmos, where we called it when it was visible absence of any ocular structure. Severe microophthalmia we called when there was visible rudimentary ocular structures with corneal diameter less than 4. Complex microophthalmia was when microophthalmia was associated with anterior segment dysgenesis. So all these 3, anophthalmos, severe mixed microophthalmos, and complex, was severe phenotype having greater impact on vision. So we clubbed them together. Here we see that the demographic data was comparable between the cases and the control. And like I said, there was regional variation in one of the institutes, where we see 124 cases in one institute, and out of that 49 were severe phenotypes. So we assessed the risk factors, antenatal fever, rashes, and all of that we assessed. Antenatal night blindness in the mother, consanguinity, order of birth, whether it was first or multiple order, family history, and vegetarian diet. 2 factors stood out were antenatal night blindness and the order of birth. So the controls had more firstborn, and the cases had more multiple borns. Severity of phenotype, if you see, severe bilateral cases where greater visual impact was there. 100 cases were there such, and out of that 50 cases had history of night blindness. Mothers had history of night blindness. Whereas in other combinations, 120 patients out of that, 23 had night blindness. 12, most of them complained in 3rd trimester. So there was only another study that was done for risk factor evaluation. It was a single location case series recruited from blind schools. So they had no age limit and a lot of recall bias. Their night blindness incidence was 16%, and ours was 33% in the MAC population and 3% in the control population. Second born affected in their study also was high, and in our study also it was high. Consanguinity and family history they had higher compared to our study. So there had been many case reports of maternal bariatric surgery leading to fat loss and leading to vitamin loss and having a MAC outcome. These are indirect evidences that I'm talking about. Multiple animal studies done over a century ago where they tried to modify and induce maternal vitamin A deficiency led to severe outcomes of MAC. that is anophthalmos, sometimes severe mixed microophthalmos. And it was done in pigs, in zebrafish, and a lot of studies are already there about the animals. Indirect evidence has a role in fetal ocular organogenesis. So when we talk about genetic mutations, definitely there is retinoic acid pathway, genetic mutations like STRA6, ALDH1, A3, RARB, but all of these have wide phenotypic variation. Sometimes it's isolated ocular, sometimes it's systemic abnormalities. Even the authors have pointed out that possibility of varying vitamin A levels during organogenesis. Need for vitamin A may be different from different organs during organogenesis. We are talking about a time where there is limited beginning of the pregnancy. So differences in timing. So there was recall bias, confounding factors were there, like any other nutritional factor could be there. Serum retinol levels were not seen. And it's one of its kind study where maternal VAD could be the only modifiable risk factor to have the outcome of severe MAC where
last
this visual
trimester they were
impairment.
asking about blindness.
Thanks. No, we did not do the vitamin A levels because it had ethical constraints. At what point would we do the vitamin A levels, which are very variable? And that's why we did the standard WHO recommended indicator, that is night blindness in mother. That will give us the cause whether she had. But no, there is a standard questionnaire for that that is recommended by WHO, and they use it for various studies.
That's very speculative. Other thing is a lot of genetics in.
Yes, but all the genetic papers mention that there is a role of vitamin A in various levels.
Any systemic association genetic study? Did you do anything to rule those things out? Because
no, it's not. The amount of patients that were there and the socio-economic status, we don't have grants for that. So as of now, we've not done, but we're going to explore it in the next stage.
That's what I'm saying. Yours is very, you have taken a conclusion and then you have gone around doing work. That's my feeling. Because other thing is that the fetal embryonic fissure closes from
at 6 weeks.
Forms around 3 weeks and closes by about
6 weeks. It closes. So
so whatever insult has to be there, has to be in that window.
Yeah.
So if you're talking vitamin A levels, had you taken in mothers, it would like folic acid. Like folic acid association with spina bifida and all that. So either you conjecture that kind of association.
So reproductive age group is the only age group where we can see the levels.
Vitamin A before they have.
No, but that is unethical. According to WHO, it is unethical to give.
That's what I'm saying. It becomes very dicey.
Yeah. So one indicator we found that
women who don't know that they are pregnant, they should take vitamin A. वो भी मुश्किल हो जाएगा.
वो भी मुश्किल.
Anyway, good presentation. Thank you.